Welcome, everyone. Let's give a few seconds for people to join. Welcome. Thank you for being on today's roundtable, and we are honored to have Dr. Rebecca Ryan. If this is your first time with us, we are Renegade Research, a decentralized, patient and caregiver-led research organization. And we have this roundtables as a way to have expert clinicians share with other clinicians and the public their expertise in various aspects of treating ME/CFS, Long COVID, and other infection-associated chronic illnesses and all of their comorbidities. So thank you for being here. After the live session, we will be posting to the Remission Biome YouTube channel. So if you're not able to stay for the whole session, please make sure to catch up with the recording. And today we have our wonderful team with us, or part of our team. We have Rochelle, our founder, Tess, Ellie, and Sam. And for Dr. Ryan, she is an Australian-trained gastroenterologist and hepatologist known for her expertise in complex medical conditions and her focus on the gut-brain connection. Dr. Ryan's extensive experience stems from completing her core gastroenterology years at the Royal Adelaide Hospital and finishing her advanced training in general and transplant hepatology at the Princess Alexandra Hospital in Brisbane in 2007. Following this, she transitioned to the private sector while also continuing her role within the Queensland Liver Transplant Service for over a decade. Her interests span from the complexities of liver transplant patients to the evolving challenges post-COVID. Dr. Ryan specializes in disorders of the gut-brain axis, which explores the links between gut dysbiosis and the effects of psychological and inflammatory stress on the body. The post-COVID era has highlighted the growing need for understanding, awareness, and recognition of these conditions, which also underpin the pathophysiological basis of Long COVID. Dr. Ryan's specialized areas encompass functional gastrointestinal disorders, such as IBS, POTS, MCAS, Long COVID and the gut, and all aspects of liver disease, as well as metabolic syndrome. And without further ado, welcome Dr. Ryan to Renegade Research Roundtable. Thank you for being with us.
Okay, well, thank you very much for having me here today or tonight. It's a great honor, and I think it's very important because we all know the importance of microbiome in all areas of the body, but particularly the gut-brain axis and how it relates, and particularly to Long COVID, ME, POTS, MCAS, and diseases that are multi-systemic, and it shows the link and the interconnections between all of the symptoms and disease processes. So just, okay. So I wanted to start by just giving a general overview of what I wanted to talk about tonight. So I'm just moving my screen. So basically, just moving it. What I plan on talking about is initially the gut-brain axis. So the gut-brain axis. No, I'm not doing that. Oh, hang on. I've got a lot of technology. I'll get there in a second. Okay, so is that working now?
No.
No, we can't see your screen.
Hang on. Hang on. Where are we? Sorry. Is that better?
Yes.
Okay. Now, why is it not working? It's not coming up. Sorry, it's not coming up with the slideshow.
If you see the top left corner of your screen, it says resume slideshow. It just disappeared.
Where was that? Sorry. No, don't know. Had it before. Is that working now?
It's not in slideshow mode, but it's visible. It looks good.
I don't know why it's not. Sorry, guys. I don't know why it's not coming up in slideshow mode. Let me try one last time. Good thing we had a practice session, hey? Okay.
If the slideshow doesn't work, you can also shrink the vertical size of the window you're looking at.
There we go.
Oh, you
That's
got it.
perfect.
Yeah.
Oh, third time.
All right.
All right. Sorry, guys. I'll start. All right. So the overview of this talk is the gut-brain axis initially and what the components are, the dysfunction of the gut-brain axis and how it leads to symptom generation. I want to talk about what we all know with respect to the Quadfecta, the Trifecta of hypermobile EDS and MCAS. And then I want to talk about symptom generation. And we know how symptoms are generated. It helps us understand the pathophysiology and then how to treat those symptoms. Talk about gastroparesis in the sick patient. We know that most of the morbidity and mortality associated with these conditions relates to the underlying gastroparesis and malnutrition. And then touch on the vascular compression syndromes, which are very common, but unfortunately there's very little known about them. So when I talk about the gut-brain axis, the components that I talk about, or what I mean by the gut-brain axis, is the bidirectional communication between the gut and our brain, and in particular in the gut, also the microbiome. And it's usually designed to describe how the brain will influence the gut with respect to its normal functions of digestion, secretion, absorption, peristalsis, and in return how the gut can influence mood, memory, and appetite. I like to view it as a highly complex communication or control network that's designed to keep the body in a state of health or well-being, and how it then leads to protecting the body or the individual when faced with a stressor. And when we look at it, it's composed of a couple of components. There's obviously the brain, the HPA or the hypothalamic pituitary adrenal axis, the autonomic nervous system with its components, the immune system, the gut, and the microbiome. This is a diagram I've designed that I use to show my patients and how I educate them and talk about the gut-brain axis. And so I begin with the brain and the links with the HPA axis, the autonomic nervous system where you have the sympathetic nervous system, which goes from brain to body or to the gut, and the vagus, which makes up most of the parasympathetic, which has bidirectional carrying signals to and from the body. And then we have the large bowel. And in the large bowel in particular, we have different components. We have normal colonocytes, which produce water and mucus and help absorb all the nutrients. We have the enterochromaffin cells in the colon, which are hormone-producing cells, and they have these very important mechanical receptors on their surface. We have tight junctions, which actually hold the bowel lining cells together so that we form an impermeable barrier. And then inside the bowel, we have a couple of components. We have feces, we have bacteria, and we have food particles. And in an ideal world, you have a state of eubiosis. So we all know that everybody has their own individual bacterial population. And when that population is diverse and has lots of different good bacteria, we call it eubiosis, and that's the ideal microbiome. And the reason that it's ideal is it exists in a symbiotic relationship with the body, so that we allow the bacteria to live in our bowel and we feed them. And in return, the bacteria make waste products or metabolites that not only communicate with the brain and control and influence the gut, but they actually communicate with every organ in the body and help and are important in maintaining that organ's state of health. And so they're extremely important. Now, When you get the opposite, which is on the right side of the diagram, when you get dysbiosis, and dysbiosis is where that bacterial population has now altered, and there's many different ways in which dysbiosis can arise. But the bacteria are now they're not as diverse, the population, and there's not as many good bacteria, if you like. And in this situation, you lose the symbiotic relationship. So these bacteria are no longer particularly interested, and they don't help maintain the function of the tight junctions. So the cells actually start to move apart, and you get these paracellular spaces, and you get increased intestinal permeability. It's not like there's a big hole, but microscopic particles now can get through the submucosa. And the layperson, we call that leaky gut. And it is a well-researched and known phenomenon, but unfortunately, it's not widely accepted in medical circles. So now you have microscopic particles of food, bacteria, and feces that can get across the gut lining. And of course, the immune cells attack and destroy these particles that are getting across in an attempt to prevent us from becoming ill. And this leads to an inflammatory process. The brain senses this inflammatory process and realizes that we're under attack and that we're defending ourselves, and it then starts to coordinate the stress response. So it activates the HPA axis, it releases the adrenal signal so that the adrenal glands start to pump out your stress hormone, your cortisol, and the effects on the body, and it activates the sympathetic nervous system. Now, when I think of the autonomic nervous system, it's not that it's ever on or off with respect to the sympathetic or the parasympathetic. They exist in a balance, and it's just which one is more active at any point in time for the given needs of the body at that time. So if you're about to eat something, you've got increased vagal activity or parasympathetic activity. If you're doing some exercise, you've got increased sympathetic activity. But when the sympathetic nervous system becomes activated because of the stress response, the main function of the sympathetic nervous system, it has many functions, but the main function is control of blood flow. And so what it does is it rediverts the blood away from the non-essential organs to the essential organs. And so if you think about it, when you're running away from a lion, you don't need your guts. If you stop to have something to eat or to defecate, you're going to get eaten by the lion. So you don't need your guts. So your anus clamps shut, your colon slows down, and your upper gut slows down. And it creates the symptoms of what we call irritable bowel syndrome. It's not irritable bowel syndrome, it's your gut responding to you being in fight or flight and not needed. Now, the way that this generates symptoms in the gut is that when the feces enter into the large bowel, they're in liquid form. And the large bowel's job is, as the feces moves along the colon, is to move the feces, but also to suck out or reabsorb all of the fluids. So that by the time it gets down to this part of the colon, or the sigmoid colon, it should be that lovely Bristol type 4 sausage-shaped motion. And now, however, when you're in fight or flight, or you've got the stress response, the gut motility is slowed down, but the water keeps getting reabsorbed. And so now you end up with hard feces in the colon. And that's what I mean. I think if you follow me on Twitter, you see I talk a lot about fecal loading. That's what I mean by fecal loading. You're supposed to have feces in your colon, but it's not supposed to be hard. And we come back to the enterochromaffin cells and these mechanoreceptors. Now the presence of the hard feces push on these mechanoreceptors, or if you get trapped air inside the bowel, that will also push on these mechanoreceptors, and they activate and then they release serotonin. Now, serotonin has multiple functions in the gut, and from the next slide, you can see all of the functions of serotonin. But basically, the main function symptom-wise is that when serotonin is released in the colon, it leads to peristalsis, pain, and can lead to the development of visceral hypersensitivity. It stimulates peristalsis and it causes production of water and mucus. So even though it was initially in a hard feces that was in there, they can then the serotonin release causes symptoms of abdominal pain, urgency, and diarrhea until all of the hard feces is moved away from the enterochromaffin cell and the mechanoreceptor, and then the symptoms ease off. It also sends a signal via a vagal nerve up to the stomach, And what it does is it slows stomach emptying, because the premise is, well, if the colon's not moving, there's no room for anything else to be coming down from the upper gut. So the upper gut slows down. So you lose your appetite, you feel sick, you have early satiety, you feel full quickly if you eat. And if you continue to eat, you can get pain or reflux or vomiting. And you can see that it also triggers inflammation and has multiple other effects, and how fecal loading also is a very important component in altering mood as well. So when I talk about functional gut symptoms, and there was a lot of controversy on some of our posts the other day, I like the word functional gut symptoms, but a lot of people, and I don't like the word functional in other contexts. Disorders, irritable bowel was the original term 30 or 40 years ago when these syndromes were designed or described for the first time. And then they realised that, well, it wasn't just the bowel, the whole gut could be involved. And so they renamed them functional gut symptoms or a functional gut disorder. And I quite like the word, because when you think, what are the functions of the gut digests, it secretes, it absorbs, it moves things. They're the functions, and they're the functions that become abnormal in irritable bowel, if you like. So it is good, but the problem with that as a name is it's the connotation of functional, which implies there's nothing wrong, or it's all based purely on anxiety or psychosocial stresses. But it doesn't matter what you call these symptoms and these disorders. Naming them doesn't really tell us much about how these symptoms are generated. And if we don't know how the symptoms are generated, we don't know how to treat them. And it's overly focused on psychological stresses as drivers of symptoms and psychological approaches to treatment. And in general, disorders of the gut-brain axis are very poorly treated. So why is the gut-brain axis and its dysfunction important if it's just irritable bowel? Well, nothing's just irritable bowel. So the problem is, we now described how the gut got slowed down, the fecal loading. And so the fecal loading causes the feces to build up, and if you like, you get stagnation, you get sort of overgrowth, not SIBO, but you get, overgrowth. And so you end up transitioning from a eubiotic state to a dysbiotic state. And remember, we said that this leads to breakdown of the tight junctions, inflammation, which furthers the stress response. And then the whole process starts to become a vicious cycle. And so you end up setting up a situation where you lead to chronic inflammation. And this inflammation is usually microscopic, but it can actually cause an elevated CRP, and no one can ever find the underlying cause of it. Now, when you look at chronic inflammation exerts pressure on the genes that you inherited, and eventually will exert enough pressure that those genes start to present as disorders. And they're called disorders of the gut-brain axis. And they can consist of any of the neuropsychiatric diseases, so anxiety, depression, ADHD, autism, you can get Alzheimer's and Parkinson's, you can get any autoimmune disorder, allergies, inflammatory disorders such as acne and endometriosis. You can get any of the metabolic disorders such as, weight gain, weight loss, diabetes, heart attacks, strokes, cholesterol, and it can also trigger cancer as well. So you can see how when this gut-brain axis dysfunctions, it leads to such a huge array of diseases and is involved in a lot of diseases. But unfortunately, most medical professionals just think the gut-brain axis is irritable bowel makes a woman more stressed, and then she gets more irritable bowel symptoms, and then she gets more stressed. And they don't realise how wide-ranging dysfunction of the gut-brain axis is. And when I look at the gut-brain axis and the components, when you're in constant fight or flight, that's what we call hyperadrenergic POTS. And when your mast cells, because when the fight or flight of the sympathetic nervous system is active, the sympathetic nervous system and the mast cells work as a functional unit. So I liken it to my patients. I say the sympathetic nervous system is the policeman and the mast cells are the police dogs. And when the sympathetic nervous system is activated, it says, look, we're in danger. I'm going to run us away from the danger while you go and find it and kill it. And so the mast cells have over 1,000 different chemicals that they can release in any combination in any part of the body. And then there is bidirectional communication between these. And so you get a feedback loop not only here, but you also get a feedback loop through the mast cell autonomic nervous system. And then you can see how activation of the mast cells can contribute to lots of different diseases, but all of the symptoms that we see. So I call this being on the merry-go-round. So once you're on this merry-go-round, you're going to end up with a lot of symptoms. And I can't get you off it until I remove some of the stress or the danger that your body is reacting to. A lot of people say, well, how do I get on this merry-go-round? How did I get in this position in the first place? And this is where the concept of stress is very important. Again, stress in the medical profession is unfortunately mainly attributed to life stress. But the word stress is anything that the brain or the body perceives as a threat or as a danger. And so, yes, it can be life stress, but inflammatory stress is one of the biggest dangers or triggers for this dysfunction in the gut-brain axis. And that can be related to an infection. And we know that with any CFS, the vast majority of these are post-viral. And like with COVID, it can also be post-vaccination as well. It can be the stress of having an operation. When you cut a person open to operate on them, the body heals by an inflammatory process. It can be exposure to toxins or mold. You can also get stress to the body with major hormonal fluctuations. And we all know that this is a predominantly female disease. And the major hormonal fluctuations in life, so puberty, pregnancy and postpartum and menopause, and sometimes just even the menstrual or the hormonal fluctuations with the menstrual cycle can also cause symptoms. You can also have stress when you have dysbiosis develop. And so poor diet and exercise, viral persistence. We know that with long COVID, patients have ongoing viral persistence in their colon or in their gut, which leads to ongoing damage and perpetuating the leaky gut. And then another important stress is damage to the or dysfunction of the vagus nerve. The vagus is very vulnerable as it exits the skull in the upper cervical spine. And particularly for people that have had neck injuries or concussions or headaches, head injuries, or our hypermobile population, where just simply poor posture with the lax ligaments can lead to anatomical variation or deformities in the upper cervical spine. You can end up impinging or damaging the vagus as it exits the skull. And if you think, okay, you've got the fight or flight, the autonomic nervous system is in a balance, and you can either become too much sympathetic, or you can reduce your vagal tone and you end up with a sympathetic predominance, or you can have both. But not only injury, we know that with certain infections, and particularly with COVID, we know that it does cause a vagal neuritis or inflammation of the vagus nerve, which can reduce its functioning and lead to stress. So that's how you got on the merry-go-round. And every time you get another stress, it sort of gets faster and faster, which means you get sicker and sicker. So how do we get you off it? Well, your body is protecting you from, the stress response is designed to protect you. But when I say to my patients, I say, the fight or flight was only really designed to be a short-term measure. You either successfully run away from the lion and you get to relax and go back into more of a vagal predominance, or you get eaten by the lion and you die. So it was only ever designed for a short-term protective mechanism. But when it's active constantly or most of the time, because you have sympathetic hyperactivity or predominance, it now is maladaptive. These functions of the fight or flight response that normally protect us, when they're constantly active, now start to actually harm us. And so we have to actually remove the sympathetic activity, or we need to remove the vicious cycle in order to get you better. And the way I view it is that the body's responding to danger. And I sort of think about it in the fact that, okay, well, we need to remove the danger. But first of all, we need to find what danger the body thinks it's protecting us from. And when I think of danger, I think most of the danger or the threats or the stresses come from the external world. And we know that the gut is the largest organ in contact with the external world. So just based on surface area alone, we know that we're going to have most of our threat from the external world coming from the gut. We also know that this is accurate because 70% of all of the white blood, or all of the immune cells in the body live in the gut. It has the largest collection of nerves outside of the central nervous system. It secretes over 30 different hormones, and it has the largest and the most diverse microbiome. So when I talk about danger in the gut, in terms of danger, the things that are dangerous are the fecal loading causes a lot of issues, the dysbiosis, the food particles. You can be allergic to a lot of different foods, but unfortunately our testing is not particularly good for non-IgE based allergies, and so we tend to downplay them and call them intolerances. The difference between an intolerance and an allergy is that an allergy is causing tissue damage, whereas an intolerance is just causing symptoms. And then you have the mast. We have lots of immune cells, but I focus on the mast cells and in their activation and degranulation. And then again, if you have ongoing viral persistence. And then obviously dangers from the external world can come from obviously life stress. It can come from the skin, the nose, the eyes, the lungs, or anywhere where we know that mast cells tend to concentrate. So why is understanding the gut-brain axis and its dysfunction important when we talk about long COVID and ME/CFS? When I talk about long COVID, I'm talking about the 80% of long COVID that is actually due to underlying POTS or dysautonomia. And when we look at ME/CFS patients, we know that they have dysautonomia, whether it's overt POTS or whether it's orthostatic intolerance with cerebral hypoperfusion, but not quite meeting the criteria for POTS. But the dysfunction in the gut-brain axis is actually pivotal to these disorders developing, but not only from the point of view of an initial trigger, but also for ongoing activity of the disease. I wanted to talk a little bit more about dysautonomia or POTS. So I view POTS a little bit differently to most people. So when you look at other people's interpretation, if you look at the Canadian Cardiovascular Society statement, they like to divide it into you have POTS and then POTS plus other symptoms, irritable bowel or migraine. And then this is describing more the ME group where you have postural symptoms but don't quite meet the POTS criteria with respect to tachycardia, and then with or without symptoms. And the problem with this is, and it's the problem with naming POTS after the cardiovascular symptoms, it implies that the cardiovascular system is the dominant system and the dominant function. It's not. It's dysfunction of the entire autonomic nervous system, which supplies all organs in the body. And so all organs dysfunction or can dysfunction. It just depends on the presentation of the patient. The American College of Cardiology like to describe it with a diagram showing POTS and then all the different syndromes or symptoms or conditions or comorbidities that can come with POTS. Then we have the good old trifecta. We all know about the link between hypermobile EDS, POTS, and MCAS. And most of the patients, because I see the hyperadrenergic form of POTS mostly, which causes a lot of the gut symptoms, we see this. I see most of my patients are trifecta patients. And we know that with trifecta patients, they have abnormalities of the connective tissue, the autonomic nervous system, and the mast cells. And you get this feedback loop because we know that the mast cells and the sympathetic nervous system have this communication where they communicate with each other and work together. But we also know that both the autonomic nervous system and the mast cells, when they're activated, control how lax the connective tissue is. And so it leads towards the development of hypermobile EDS. And we also know that when you have hypermobile EDS or you have increased capacitance in your veins, you're going to have more pooling, which is going to worsen your POTS. And so you can see why these diseases coexist. And Dr. Andrew Maxwell has taken it further and described the pentad super syndrome, which is the basic trifecta, but with the additional diseases of autoimmunity and gastroparesis. And then he shows the various sub-syndromes of the pentad super syndrome, where you have these and then you have all of the other comorbidities or other issues that can stem from this. And whilst this is good, to me, it doesn't make sense. And so the way that I like to think of dysfunction in the gut-brain axis is more from a point of view of a Quadfecta. And I think that we miss the underlying metabolic derangements that you get when the HPA axis is dysfunctional. So the Quadfecta talks about, yes, the traditional trifecta, but there are also significant metabolic derangements that we need to address, and particularly in the gut. And if we don't address those or we miss those, they contribute to the ongoing symptom burden that our patients experience. And so I think of it as more of a Quadfecta. I put the hypermobile EDS out there because these are the primary dysfunctions in the gut-brain axis, and then they contribute to the connective tissue laxity. Now, when I think of the Quadfecta, we all know that some people can present with mild disease, or some people can present with severe disease. You can also have people present where each of the components are equally contributing to symptoms. Or you can see it where people have one dysfunction in one of these aspects predominates. And the problem with when it's severe and they're all present, we identify them. In the mild patient, a lot of times we don't, they might have irritable bowel and migraine and endometriosis. And we think this person's unlucky and just has 3 separate diseases. They don't, they're all linked. But because they're mild, you don't see the link because none of these diseases is severe enough to sort of end up warranting a diagnosis in its own form. And in this situation where you have disproportionate presentation of a disease, where most, say somebody's presenting with POTS, the other components get missed and they are thought not to occur because they're overshadowed. But regardless of whether you've got POTS, and particularly if you've got the hyperadrenergic form, you will have aberrant mast cell degranulation, whether it meets the criteria for MCAS. You will have an abnormality in your connective tissue. It's just whether it meets the criteria for hypermobile EDS, and you will have metabolic derangements as well. Now, the problem I have with hypermobile EDS is we know that each of these components can exist on a spectrum of severity. You can have mild POTS, you can have severe POTS, it's still POTS. But the problem with hypermobile EDS, as separate from the other forms of EDS, is that it's disproportionately focused on the musculoskeletal complications of connective tissue flexibility, and particular what your skin and 5 particular joints are doing. But the connective tissue goes through the entire body. And so you might not have particularly mobile joints, and we all know that there's the stiff hypermobile patient who no longer is hypermobile, but you still have an abnormality in your connective tissue. And if we ignore this, then we're ignoring all of the complications that arise because of connective tissue issues. So I like to think of it as metabolic derangements, POTS, mast cell problems, and connective tissue issues rather than hypermobile EDS. And this is how the Quadfecta relates to the gut-brain axis. I look at each of the components of the gut-brain axis. So you have the brain, the HPA axis, the autonomic nervous system, the immune system, and the gut. And when it's dysfunction, I look at the diseases that presents, and then you can see how all of these patients can get any combination of any of these diseases. So when their brain develops neurological or psychiatric conditions, when the HPA axis is dysfunctional, you can get metabolic problems, and cancer is thought of as a metabolic disease. The POTS, and the immune system has so many diverse functions. You can get MCAS, you can get allergies, you can get inflammatory disorders, and you can get autoimmune disorders. And then the gut and the microbiome are contributing to the functional gut symptoms and nutrition. So how does thinking of the gut-brain axis in the terms of the Quadfecta help me? Well, when I see a patient and I think they have dysfunction in the gut-brain axis, so I think, okay, well, they're going to have abnormalities in each of those 4 areas. What I really need to know when a symptom arises is which component of that Quadfecta is causing the symptom. And sometimes it's only 1, sometimes it might be 2 or 3. But which component is it? Because once I know which component is not working well, then I can look at, okay, that component is then caused by stress, and I can look at the stress, and then I can see how does that stress or that trigger lead to dysfunction in that component. And it allows me to understand the underlying pathophysiology of that symptom generation. And if I don't understand how a symptom is being generated, how do I treat it? I need to understand, and that's the problem with functional. We just think it's this magic stress causes symptoms. Stress doesn't cause symptoms by waving a magic wand. It still causes symptoms by underlying physiological, pathophysiological basis that you can identify, target, and treat. So when I look at the gastrointestinal symptoms or functional gut disorders, the vast majority of these symptoms are due to the hyperadrenergic POTS. So the slowing of the colonic motility leads to the fecal loading, which then causes both lower GI and upper GI symptoms. The other components cause their own symptoms, but the burden of symptoms is from the POTS. And so the mast cells tend to cause pain, particularly epigastric pain, and they contribute a lot to the visceral hypersensitivity or that we describe and see often in these patients. When we eat foods that we're allergic to, the mast cells are responsible for causing symptoms. And then there's the concept or the problem of histamine intolerance, which is in your food, which is activating your mast cells. The dysfunction of the HPA axis leads to, and we'll talk about this later, what I call dysautonomic diabetes. And it also contributes to weight gain and loss. And then the connective tissue abnormalities lead to visceroptosis. And so visceroptosis is where, when you stand up, the organs in your abdominal cavity, because of how lax your connective tissue are, they drop under the weight of gravity. And then that causes symptoms. And it's not very well appreciated. And the connective tissue abnormalities also underpin and drive the vascular compression syndromes. So when I want to come back to fecal loading, because the two most important gastrointestinal symptoms, and not just for gastrointestinal symptoms, but for the general sort of well-being of the patient, are fecal loading and nausea. And fecal loading, again, is not constipation. Constipation is what the patient tells you. Fecal loading is a clinical diagnosis. It's not a symptom, and it's the presence of hard feces in the colon. And you can have fecal loading and have absolutely no gastrointestinal symptoms, but you can have constipation, diarrhea, alternating constipation or diarrhea, or you can have any of the upper gut symptoms. Diarrhea, or what I call true diarrhea, is mast cell driven, and it responds quite well to Montelukast, H1, H2 receptor antagonists, and things that target mast cells and stabilizes them. The difference between diarrhea from fecal loading is the clue is the presence of the accompanying symptoms. So if you have pain, which then becomes relieved by passing emotion, the motion from the first one to the last one becomes progressively looser to the point where it can be explosive. If there's excessive mucus, mucus is telling us the bowel is trying to lubricate the hard feces out, lower abdominal bloating, or the presence of upper GI symptoms, then it tells you that your diarrhea is because you're fecally loaded. Whereas if you have true diarrhea, which is mast cell driven, you're just going to have diarrhea. The consequences of fecal loading are important to the whole gut-brain axis, because fecal loading actually worsens the underlying hyperadrenergic state. It contributes to mast cell degranulation, and it worsens the dysbiosis, which increases the intestinal permeability and drives the ongoing dysfunction in the gut-brain axis. Pain can also drive the underlying hyperadrenergic state, and fecal loading is the most common cause of nausea, and then this can lead to a downward spiral. And what people don't appreciate is what I call concreted feces. Before COVID, I didn't see fecal loading very often. I would feel, masses of feces in someone's abdomen, once every 2 or 3 months. Obviously, when COVID hit, it disproportionately, when you see patients, it disproportionately affects the autonomic nervous system rather than mast cells, in my opinion, because the fecal loading since COVID is out of control. Every single person I have is fecally loaded that comes in with functional gut symptoms. I used to have 50-50 diarrhea predominant and constipation predominant. I used to use a lot of amitriptyline. I can't use amitriptyline anymore because of its constipating side effects. Concreted feces, I like to think of, when you think of fecal loading, there's two components. There's the backlog, and then there's the feces that are coming through. And when you treat it with laxatives, the aim is that you need to clear the backlog, which is there, but then you need to keep on enough laxatives to prevent it from recurring. But the problem is when you get severe fecal loading and it causes nausea, people start to reduce their oral intake. And we all know that the basis of management of POTS is drink 2 to 3 litres of water a day and 10 grams of salt. But when you feel sick, you simply can't face the fact of drinking 2 to 3 litres of water a day. We know that patients with POTS are walking around in a hypovolemic state. We've already got a colon that's slowed down and is not moving, and so the feces are having all of the water being reabsorbed, and that's what's contributing to the fecal loading. But when you have a hypovolemic POTS that then is so fecally loaded that they're not drinking and it worsens their hypovolemia, we all know the patient that has to have intravenous fluids to be able to stand up. The body is going to prioritise the blood volume over the water in the colon. And if you have chronic diarrhea, your bowel can adapt, and it can get to the point where it's capable of reabsorbing up to 5 litres of fluid a day. So if you're walking around constantly hypovolemic from your POTS, you are going to suck even more fluid out of the colon. And I use my sponge analogy. We all know you've got a brand new fresh sponge and you put water in and it soaks it up and you can use it. But picture you've got the sponge that's been sitting on the sink for 3 months and is rock hard and dry, and then you go to use it. You put the water in and it takes about a minute before it's able to absorb enough water to then actually be used as a sponge. And the feces become so hard and concreted that when you put laxatives or bowel prep down them, they just can't have enough contact with it to reabsorb the fluid that's in the bowel prep and is being pulled in through osmotic forces from the bowel prep to actually rehydrate enough and it can break out. And so when this happens, and if you don't get the fecal loading out, you're not going to control the dysfunction. You're not going to control symptoms, but you're not going to control dysfunction in the gut-brain axis. And so I have had to resort to colonic irrigation, which is not something I thought I would ever say. But the advantages of colonic irrigation is that for 45 minutes, water is bathing your colon and soaking your feces and softening them up. And I do have a small subset of patients that are so hypovolemic that they actually gain weight after a colonic irrigation because they absorb that much water from the bowel into their blood volume. And if severe, I have patients that need to have them, twice a week for, 12 irrigations before we finally clear the backlog, and then they can start to improve. The downward spiral is something that's really concerning to me, and we know that the gastrointestinal complications have one of the highest morbidities and mortalities in this group. It begins with the fecal loading, which is then the most common cause of nausea. Once the nausea is severe enough, it compromises oral intake and nutrition, which then worsens the POTS, will activate more mast cells, and will make the fecal loading worse. And so you just get this vicious cycle where they get sicker and more malnourished and more fecally loaded and more POTSy and MCASy. And then the connective tissue issues then can lead to triggering or exacerbating underlying vascular compression syndromes. So when I look at nausea as a symptom is an example of how all 4 areas of that quadfecta play a role. When I look at the gastrointestinal causes of nausea, the most common we've talked about is fecal loading. Fecal loading tends to cause constant baseline nausea. Hypovolemia from the POTS in itself can cause nausea. And that nausea is typically, you say to a patient, you wake up in the morning, do you feel nauseous, yes or no? Now you stand up. Does your nausea get worse? And you will have a subset of patients that when they stand up, and particularly in the morning, because we know that POTS has that diurnal variation and it's worse in the morning, that their nausea and vomiting occurs only after they assume the upright position. So if you get that history of postural nausea and postural vomiting, it's not a gastrointestinal problem. It's a hypovolemic problem, and these patients need to focus on volume replacement with salt and water or intravenous fluids if they can't get it in orally. Now, the next most common cause of nausea is dysfunction in the HPA axis, and it's what we call postprandial hypoglycemia. So when it's gastroparesis, not gastroparesis, it's when it's actually dysautonomic diabetes. Now, I've made this term up because no one else seems to know about it, but we know that our ability to distinguish based on clinical history between rapid, normal, and delayed gastric emptying is terrible. You're more likely to get it wrong than right. But when we look at people with POTS, they're more likely to have rapid gastric emptying than delayed gastric emptying, despite what we all think that these patients all have gastroparesis. We don't quite understand the mechanism, but we know that when you have rapid gastric emptying, it leads to dumping of nutrients, and in particular glucose, into the duodenum. This then gets absorbed and leads to hypoglycemia. And then this has a couple of consequences. The body then puts the brakes on gastric emptying and actually delays gastric emptying until it's had time to deal with the glucose level and bring it back to a normal level. So this causes postprandial nausea, particularly with carbs. And so even though it's rapid gastric emptying, it ends up causing delayed gastric emptying and symptoms of delayed gastric emptying. Now, when glucose is present in the duodenum, it leads to release of GIP. Now, GIP is one of our most potent splanchnic vasodilators. So we already have a hypovolemic situation. We have poor perfusion to the brain, and then you eat sugar, it gets dumped into the duodenum, we get this massive release of GIP, and all the blood gets pulled into the abdomen, the splanchnic circulation, in an attempt to try and carry that glucose away to the liver to be processed. And so these patients complain of symptoms of postprandial worsening of their POTS. And so particularly when they eat carbs, and sometimes it's just when they eat any food, they get worsening of their POTS symptoms. So they complain of brain fog or tachycardia or shortness of breath, or they just have to lay down and have a nap every time they eat, which can then lead to them not eating and becoming malnourished. The GIP then also causes insulin release, and the mismatch in insulin and timing and glucose can lead in some people to development of reactive hypoglycemic episodes, where anywhere from 30 minutes to 4 hours after eating, their blood sugar will drop low enough to precipitate a hypoglycemic episode. Now, remembering back to when I said before, we need to remove danger in order for our patients to get better. When I talk about external dangers, there's also internal dangers. And one of the most dangerous internal stresses is hypoglycemia. So if you are having a hypoglycemic episode, it's going to be one of the most potent activators of both the sympathetic nervous system and of mast cell degranulation. But nobody appreciates that these patients are having hypoglycemic episodes because, one, why would this person have diabetes, and why would this person be having hypos? They're not on insulin. And the hypos can occur in any form. They can be reactive, so after eating. They can be in a fasting situation, and they can also occur in the middle of the night. And so I usually ask my patients symptoms like, do you get hangry? Do you ever feel like you're suffering from symptoms of low blood sugar, and when you eat, these symptoms resolve? Do you ever suffer from night sweats or nightmares? And no, it's not always menopause. And do you suffer from unexplained adrenaline dumps or unexplained POTS flares? Because whilst POTS does have activity, if your POTS suddenly gets worse, you need to have a look at why. Something has obviously triggered it to get worse. It just doesn't flare on its own. And if you don't know what's triggering it to get worse, then you can't remove it. And I find a lot of my patients have PTSD as a comorbidity. And I find that a lot of the flashbacks and the nightmares in this patient cohort are actually being driven by unrecognized hypoglycemia. And I even have about 10, 15 patients whose hypoglycemia is severe enough to trigger seizures. The trouble is, none of us really are aware of what a hypoglycemic seizure looks like. There's no reason for these patients to be having a hypoglycemic seizure because they're not on insulin. And they present with an atypical seizure that usually gets labeled as FMD or psychogenic epilepsy. But you treat the hypoglycemia, the seizures go away. So when do I do gastric emptying studies? I don't actually do gastric emptying studies anymore. And the reason of that is because no one ever checks to see if the patient's fecally loaded before they do a gastric emptying study. No one checks in a non-diabetic whether they're having postprandial hypoglycemia before they do a gastric emptying study. And no one checks to see whether or not the patient has gastroptosis, MAUS, or SMA syndrome. And we'll talk about those a little bit later. So basically, these make the gastric emptying study pretty much useless in this patient population. And if the gastric emptying study is normal, but you're describing symptoms of gastroparesis or through vomiting food that you digested 15 hours, you ate 15 hours earlier, regardless of what the gastric emptying study says, you still have gastroparesis. The study was just negative. I just want to quickly go through this and we can come back to this later. So when I look at the gastrointestinal symptoms, I divide them into the area, the symptom, and then the underlying part of the quadfecta that's causing it. So when I'm talking about functional gut symptoms, I'm assuming you've had an endoscopy and colonoscopy and basic bloods and they're all normal. Eosinophilic esophagitis should have been picked up, but I view eosinophilic esophagitis as the esophageal manifestation of MCAS. You can get dysmotility that causes dysphagia with POTS, and the clue on history is that it's dysphagia to both food and liquids. And I generally don't find that I don't have to do anything for that. If you treat it, if you treat the POTS, it gets better. Reflux, the classic acid reflux is you have symptoms of reflux and you take a PPI and it goes away. But if you see severe acid reflux that responds to a PPI in a thin young woman without a hiatus hernia, you should have big alarm bells ringing in your head because reflux is the domain of middle-aged, overweight men. And so if you have a thin woman who has severe endoscopic proven reflux, it responds to a PPI. Why? And it's usually they're fecally loaded and they've either got a lapsed geojunction or a very, very tiny hiatus hernia that's allowing the acid to go up. Then when you've got acid reflux not responding to a PPI, this is what I call esophageal hypersensitivity, and this is mast cell driven. Then you have passive volume reflux, and this usually occurs in conjunction with gastroparesis, and this is different to rumination, and I won't go into that details, but it's basically you have gastroparesis, you bend over, or you have passive reflux of contents all the way up into your esophagus. Sorry, my cat has come to visit me. And then with the stomach and the small intestine, you can have the upper jump GI symptoms, and you can have any of them. And most of them are driven by the POTS. So the nausea, the postural nausea, and the postprandial nausea. The epigastric pain is fecal loading, or if we talked about functional dyspepsia before, it's usually mast cell driven if it's caused by these precipitants. Postprandial symptoms, a lot of people have postprandial diarrhea and they think that what they're eating is coming out. And so we used to call this an exaggerated gastrocolic reflex, but depending on when it occurs, it's either an exaggerated gastroileal reflex or an exaggerated gastrocolic reflex. So if the patient is eating their meal and they have to put their fork down halfway through the meal and run to the toilet, this is due to loading in the proximal colon, and it usually implies POTS and vagal injury in the upper cervical spine because the vagus supplies the entire gut and then it runs out somewhere along the transverse colon. The rest of the colon is supplied by the parasympathetic innervation is supplied through the lumbosacral spine. So if you have vagal dysfunction, this part of the colon doesn't particularly move well, and so it becomes fecally loaded. When you eat, the first reflex that occurs within 2 minutes of eating is the gastroileal reflex. And what that does is, as soon as food is in the stomach sends a signal down to the terminal ileum and it says, food's coming through, you need to start moving your contents. So it pushes feces into the right colon, but the right colon's already so fecally loaded that just the presence of a little bit more volume of feces stretches the colon, activates the mechanoreceptors, and patients get pain, urgency, and diarrhea. About 20 minutes after eating, the gastrocolic reflex occurs, and it sends a signal to the sigmoid colon. So when people get postprandial diarrhea that occurs about 20 minutes after eating, this usually implies that they're loaded in the left side of their colon. Then the postprandial worsening of the POTS we talked about was rapid gastric emptying, and we'll talk about gastroparesis-like symptoms in a minute. SIBO, 80% of people have a incompetent ileocecal valve. If you're grossly fecally loaded, you end up with bacteria being pushed back into the small bowel. So SIBO, I don't believe, in the absence of anatomical and abnormalities or surgery or blind loops, I view it as secondary to an underlying motility disorder. And so it's usually the patient is so fecally loaded. Now, I don't need to treat or look for SIBO because I find it's the last test I do. And usually what happens is when you treat the fecal loading, the patient finds that their symptoms go away and they don't need to be treated. But if you treat them when they are fecally loaded, then they will get better. But as soon as the antibiotics stop, the symptoms come back again. Then we won't go into this one, but we can come back to this. The gallbladder, liver, and pancreas can all have their own type of problems. And lower GI symptoms we've talked about already. And then rectal symptoms we can come back to later if there's time. So I want to move on to gastroptosis and the vascular compression syndromes because I think that these are causing significant problems in my patient population and they're really underappreciated. So just like you can have visceroptosis, which is the viscera or the organs dropping, gastroptosis is the stomach dropping. And so it's the downward displacement of the greater curve of the stomach under the influence of gravity. It can be asymptomatic and just there, or it can cause epigastric pain, nausea, vomiting, early satiety that occurs in the upright position. So it's important when patients describe symptoms of gastroparesis, whether they're there all the time or only in the upright position. But the problem is most people only eat in the upright position. And it's thought to be caused by excessive laxity of the abdominal wall. But in hindsight, I think it only occurs in people that have connective tissue abnormalities. The problem occurs is that it's the body of the stomach that drops and the pylorus and antrum maintain the position which is slightly above. And what happens is that you get some patients present with gastroparesis because the stomach can be so low. It's almost as if in the upright position, the food can't be pushed out of the stomach uphill against gravity. The problem that I have with gastroptosis, so this is a girl that had a barium swallow and follow through, and this is her in the supine position. And you can see that it's supposed to be, the stomach's supposed to be at the top of the L3. And then she stands up and you can see that her stomach drops. And so these are the top of her hip bones or iliac crests. And the greater the curve of the stomach is actually outside the picture and it's sitting on her bladder. Now, what the studies don't, there's not much in the literature on gastroptosis, but what they don't describe is that most of the abnormalities appear to be occurring in the body of the stomach. And it's as if the connective tissue in the body of the stomach is collapsing under its weight and it ends up forming this hourglass or corset-like picture. This is liquid. Liquid should completely drop and then fall and empty out of the stomach quite quickly. This is at 20 minutes and you can see that she's got an air fluid level, which means that this little funnel here or this constriction is actually forming a pouch, and she's getting a delay up here. So gastroptosis can cause a delay in gastric emptying because it's forming this corset in this upper pouch. Or then sometimes, even if the fluid sits down here, it just can't seem to climb out against gravity and get out of the stomach. But again, the reason why I don't do gastric emptying studies is that most of our gastric emptying studies, there's no real uniformity, but the vast majority of them are done in supine position, which is a bit artificial because one, most of us don't eat lying down, but two, if you have gastroptosis causing your gastroparesis, it's not going to be evident on a lying gastric emptying study. The last cause of nausea is the underlying vascular compression syndromes. Now, vascular compression syndromes are where a vascular structure, so either a vein or an artery, is either compressing another adjacent structure or is being compressed by an adjacent structure. And the problem with them being named vascular compression syndromes is that it assumes that it's the vessel that is causing the symptoms. And what we do know is that you can have neurogenic symptoms, and you can also have, particularly with SMAS, the symptoms are due to the duodenum being compressed. But people that, I mean, most people will never see one of these in their life, and so they think it's the vessel being compressed. There's 4 inside the abdomen. Now, vascular compression syndromes are supposed to be rare so that they occur in less than 1% of the population. And it's thought that you are born with the anatomy and something happens and then it becomes symptomatic. So it goes from being a vascular compression anatomy to a vascular compression syndrome. But even if we're generous and say that each vascular compression syndrome has an incidence of 1 in 100, if I have my typical Trifecta or Quadfecta patient, they will have a thoracic outlet, they're more likely to have internal jugular vein compression, and they'll have 2 or 3 or 4 vascular compression syndromes inside the abdomen. So clearly I can't be looking after 1 in a million or 1 in 10 million risk patient that has all these multiple vascular compression syndromes. So it's obviously the abnormalities, and it's the abnormalities in the connective tissue that are contributing or causing these vascular compression syndromes. The first one is the median arcuate ligament syndrome. So the median arcuate ligament is this fibrous arch of the diaphragm that compresses the celiac artery and the celiac ganglion, which is the largest sympathetic ganglion in the body, during expiration. And we think it's the traditional view is that it's because the celiac artery arises higher. It should come off down here so it doesn't get squashed or compressed. And the traditional view was that it was vascular pain and it was ischemic in origin. But this occurs in young people who have extensive collaterals. It's not vascular compression. It's compression of this sympathetic celiac ganglion that's causing neurogenic pain. And even though there is the recognition that it's a neurogenic pain syndrome, we still rely on seeing compression of the celiac artery on imaging in order to diagnose it. And we don't have tests to look for compression of the celiac ganglion. So it tends to cause neurogenic epigastric pain postprandially. It can cause gastroparesis-like symptoms, and it's actually more likely to be associated with a delay in gastric emptying in studies, but whether or not it's true gastric emptying or the other conditions we've talked about. And so what happens is as you breathe in, if you like, the diaphragm, the lungs expand and the diaphragm flattens out and it becomes horizontal. And then when you breathe out, the volumes increase, the diaphragm tense, and you get this compression. I think they talk about the values in 70% stenosis, so anything greater than 200 for a peak systolic volume, a velocity for the celiac artery greater than 200 suggests a 70% stenosis. I've found that unless you see a PSV in expiration of greater than 300 and a deflection angle of greater than 50, you're really not going to see anything on CT. The deflection angle is the difference between this angle here and this angle here. And it's because as you breathe out, the ligament hits the artery and flips it up. And so sometimes you'll see a large deflection angle, which to me tells me the median arcuate ligament is hitting the artery and bouncing it up, but you won't see a compression of the artery. And it's really difficult when patients have the symptoms and they have this finding, but no one will operate on them because they're not the classic findings. This is a patient with a classic beautiful median arcuate ligament compression. So this is inspiration. This is her celiac trunk with a celiac artery. And then in expiration, you can see on the 3D reconstruction that the artery has been completely compressed. When you look on this view, here's the aorta and here's the celiac artery coming off. And then in expiration, there's this defect here where the flow through the artery is interrupted because of compression by the median arcuate ligament. Treatment is an evolving field because I don't particularly want to operate on these people, and I don't particularly want to, when you cut the median arcuate ligament, you also destroy the celiac ganglion. And the celiac ganglion is important because even though it's a sympathetic ganglion, it does have a connection where the vagus makes a projection go through and then into the splenic nerve, and that forms the anti-inflammatory reflex. And so I'm really loath to destroy one of the most important functions of the vagus nerve, which is the anti-inflammatory reflex, if I don't have to. So I'm still sort of trying to decide what to do with my patients and trying to get them better without resorting to surgery. Now, SMA compression of the third part of the duodenum is thought to be the most rare, almost uncommon of all of the intra-abdominal vascular compression syndromes. The other two are left renal vein compression or nutcracker, or left common iliac vein compression, or what we call May-Ferner. Now, I think the reason that it's thought to be the least common is just because of the lack of understanding. When I say SMA compression syndrome, it makes you think that the SMA is being compressed, but it's not. It's the SMA, which is the superior mesenteric artery, that's compressing the duodenum. And so if you're not particularly aware of the nuances of this, you order a Doppler ultrasound and you look through the flow through the superior mesenteric artery and it's normal, and you go, no, it's not increased, the vessel's not being compressed. Okay, we've ruled that out. When you look at the anatomy, so this is the celiac artery, and that's where it gets squashed by the median arcuate ligament. The second artery off the aorta is the superior mesenteric artery. And as you can see, here's the stomach, the first and second parts of the duodenum, and as the duodenum part, the third part passes under here, it can be compressed. So when you look at it from the side view, you have the aorta, you have the superior mesenteric artery, you have a fat pad, you have the left renal vein here, and the third part of the duodenum here. When this angle gets narrowed, it compresses both the left renal vein and the duodenum. And so usually if a patient has a left renal vein compression, there's a high chance that they'll either have the superior mesenteric artery anatomy, meaning it meets the criteria that's not causing symptoms, or it's causing symptoms. Very occasionally you have an SMA that comes around like this and then down. And so you have a large angle and it doesn't squash the left renal vein, but it will compress the duodenum. So when you look at risk factors for the SMA compression of D3, its traditional risk factors are thought it's when kids go through puberty and they have rapid linear growth and no weight gain, and exaggerated lumbar lordosis. So the more lordotic your spine, it pushes the aorta closer to the SMA and squishes it. I find all my patients have a mild scoliosis that have this high insertion of the ligament of Treitz. So that's when you had a look before, you have I'll go back here, you have this is the ligament of Treitz here. It holds the duodenal jejunal flexure up. And so if it's short, if you like, it pulls the duodenum up and wedges it up underneath the SMA. A low origin of the SMA. And we do know that there is a well-known association between POTS and hypermobile EDS and median arcuate ligament syndrome. And initially I was very focused on the MAOs and didn't realize the SMA was causing most of the syndromes. And so what I now realize that if my patient has a MAOs, they will also, in my experience, have an SMA compression as well. But the converse doesn't hold true. If they have SMA compression, they don't necessarily have MCAS. And we traditionally think of vascular compression syndromes as occurring in isolation. And so I've started to have my first few patients go to surgery. Unfortunately, I haven't had great results because by the time they've presented to me, they've already had feeding tubes for 2 to 3 years before I've met them. And I can't convince the surgeons that they have both vascular compression syndromes. And so they get one treated and not the other. And so it's difficult to get a good outcome if you're going to surgery and you're only getting one of your components treated. We also know that weight loss, because the traditional teaching is that when you rapidly lose weight, you lose this fat pad, which allows the SMA to compress against the aorta. You can see it with bariatric surgery. And sorry, I didn't put a picture up. When you have a Roux-en-Y gastric bypass, the third part of the duodenum is no longer in continuity with where the food goes because it's been bypassed. And even though the food doesn't go past that area, you can still get pain, which is unfortunately misunderstood, because in here, the first celiac, there's a celiac ganglion or celiac plexus, which is the largest sympathetic ganglion. And then there's a whole nother ganglion or plexus called the superior mesenteric plexus of nerves that runs through here. And so when you eat, the blood flow through these arteries increases. And if you've got a very small space, as it's pulsating, it's going to hit those nerves. And so you can get a neurogenic component of the pain rather than an obstructive pain. Scoliosis surgery, but 40% occur without these traditional risk factors. And I find that most of my patients present when their POTS and their MCAS get severe enough that it causes a flare. They get fecally loaded, they get nauseous, they get worsening of their POTS. And I think it's the flare in their POTS and their mast cell activation syndrome that leads to their connective tissue becoming more flexible and allows, when they stand up, because the SMA compression is worse in the upright position, allows the SMA to fall onto the aorta because the connective tissue supports are no longer strong enough to support the SMA and hold it off. So symptoms of an SMA compression can be any combination, which makes it even more difficult. They can present acutely, subacutely, or chronically. You can have obstructive symptoms where food gets stuck versus neurogenic symptoms where it's the pulsatile SMA compressing the nerve plexus there. You can get incomplete obstruction or complete obstruction, and you can get it with or without left brain vein compression syndrome. The symptoms mimic gastroparesis. So these patients have postprandial nausea plus or minus vomiting. And so the postprandial symptoms are obstructive. It's food going through, and then if they don't tolerate food, you go to a pureed or a liquid diet. If they're vomiting, it suggests a complete obstruction. When they go from having just postprandial pain to chronic pain at rest, which then exacerbates postprandially, this is when I get really concerned, because this is when the pain is now neurogenic. And like nerve pain, it doesn't always resolve when you take away the irritant. And so I think it's very important that we treat these patients before they develop chronic pain. The other problem with these patients, and we all know that this group of patients has a high misdiagnosis rate for functional gut disorders as well as eating disorders. And in my experience, the vast majority of the girls that they're all girls, and they're usually between the ages of 14 and 30, they have a high co-occurrence of autism. And we know that women are expert maskers. And so when they're in severe pain, they're neurodivergent and they don't display the typical features of pain. They don't look like they're in pain. They don't behave in the neurotypical way of pain. And so their autism is usually undiagnosed. And when they don't behave in the typical neurotypical way of pain, they're assumed to not be in pain or to be faking it or to be lying and having an eating disorder. And so a lot of these girls are misdiagnosed and go a long time before they get an adequate diagnosis. It can present with early satiety, and it can present with an epigastric fullness, and they usually actually get bloating, but they'll get like a little pocket or a distended bubble, and that can form a hard lump. And if that's located lower in the abdomen, then they probably have gastroptosis as well as SMA compression, because you can get those two co-occurring. The finding with endoscopy you see is a J-shaped stomach, which is where so you go down, and as you come out, the antrum is higher than the incisura of the stomach. You get a massive increased fluid residue despite an adequate fast, because these patients are walking around before their endoscopy, and any fluid that they drank 6 hours earlier, the compression's worse in the upright position, and they just can't empty their stomach. And so they've definitely fasted for 6 hours. Their stomach should be empty. There's tons of fluid in the stomach, and usually someone makes the comment, oh, they must be anxious, because we know that that delays gastric emptying. They'll also get enterogastric bile reflux, because the compression, the common bile duct enters just before the SMA compresses the duodenum. And so any bile that comes out the common bile duct can't pass down the gut. And so instead, it goes back up into the stomach. And then at the side of the SMA pulsation, you see the compression. So this is the diameter of the duodenum proximal to the compression, and it's large enough that it doesn't actually fit in the picture. And this is the diameter of the duodenum where the pulsation is. Keeping in mind that the best position for SMA, the position that decompresses the obstruction, is the same position that we do endoscopy in, the left lateral position. So these people will give you the classic history of, I get this pain, and you say, which position makes it better? And they'll say, I lie on my left side in the fetal position. And that's the same position we do them at endoscopy, and it opens up that angle the most and allows the food to go through. So if this is compressed in the best position, you can only imagine what it looks like when the person's upright and walking around. How do we diagnose it? We diagnose it on the basis of this angle. And it's normally 38 to 60 degrees, but in SMA syndrome, it can get down to 6 to 18 degrees, and I've seen it lower. We also talk about the aortomesenteric distance. So that's the distance between the aorta and the superior mesenteric artery at the level of the third part of the duodenum. It's supposed to be between 10 and 28 millimeters, which is half an inch to an inch. But in these patients, it gets down to 2 to 8 millimeters. If you think that each wall of the duodenum is 1 millimeter, and then they've got to fit food contents, fat, and these splanchnic plexus nerves in there, and it's only 2 millimeters wide, you can see why these patients run into trouble. But the problem is that, one, we don't know about this, but when we see these patients meeting the criteria, just because you meet the criteria doesn't actually mean that that's what's causing your symptoms. And there was a study that looked at 100 routine CT abdomens done for other complaints, and they found that a quarter of patients met the criteria. I reviewed my first 20 gastroscopies of this year in patients that had POTS, or I was scoping them for, some of them didn't have upper gastrointestinal symptoms. They were had an endoscopy and a colonoscopy for further investigation of functional gut symptoms. And I found 13 of those 20 patients had some moderate degree of compression by the superior mesenteric artery. One of them had a confirmed SMA compression. 2, I was highly suspicious that that's what their symptoms were caused by prior to the endoscopy. But the other, that should be 11. But the other 11, no, it should be 10. The other 10, I did not believe that their symptoms were related to that. So one, it's thought not to be very common. I find it extremely common, but just because it's there, it doesn't mean it causes the symptoms. So I've designed a protocol that looks for a functional study. And so I get these girls to swallow gastrographin, which is a radiopaque water-soluble contrast material of about 100 mils, and a marshmallow soaked in gastrographin. And I only give them one marshmallow because you picture how big a marshmallow is to 2 millimeters, so it can get stuck. And I do it in the upright position first to see, do they have gastroptosis? And if they do, how severe it is. And is the gastroptosis just an anatomical variant, or is it causing a delay in gastric emptying? If the contrast passes into the duodenum, I want to know, is the proximal duodenum dilated, meaning this obstruction's been there for a long time and at high grade? Is the contrast in the first and second part of the duodenum going back and forth, so retroperistalsis, because it just can't get across the compression? How long does it take to get from D1 to D3? I mean, it's literally 3 centimeters, so it should take a few seconds. Is there narrowing or paucity of contrast at the level of the SMA compression, and how long does it take to get through? The SMA compression is worse in the upright position, so we do it upright, and some people will have a complete obstruction in the upright position. So we then lay them on their back or supine, which then decompresses it a little to see if the contrast will pass through. And then if the contrast doesn't pass through, that we roll them onto their left side with their knees up, which is the best position to see, is this a complete obstruction in all positions, or if we decompress them in the left lateral position, will they actually allow some contrast or liquid to go through? This is a girl that I had chronic SMA compression, and then she started to get, she presented with an acute, and then she started to get subacute compressions, which interestingly coincided with her menstrual cycle each month, which to me tells me the mast cells are involved. And so you can see this massive dilatation of the stomach. This is her nasojejunal tube. This is the proximal duodenum, and you can see how large this is. And then you can see that the bowel, where the tube goes through, you just can't even see any size of the bowel there. Here's the stomach, here's the massively dilated proximal duodenum, and then the tube goes through over here. And you can see it goes from this diameter to having to fit between that tiny space. How do we manage it? Again, I don't particularly want to go to surgery. Weight loss, the focus, unfortunately, is it's all weight loss. Everyone assumes that weight loss has caused it. But a lot of times, weight loss is not the cause of the compression, it's the consequence of the compression. And then it then contributes to ongoing weight loss, which will then exacerbate the compression. These girls are all hypermobile, and they tend to have an exaggerated lumbar lordosis. And so this is the straight or the normal lumbar lordosis with the normal angle. This is someone with a normal lumbar lordosis with a reduced angle. And then when they have a really exaggerated lumbar lordosis, it pushes the aorta closer, and so it compresses it even further. So if you identify it early on, I send them, I mean, they should have a specialist hypermobility physio. I send them to one to try and strengthen their glute muscles, which will help them reduce their lumbar lordosis and prevent any contribution from that contributing. We then do dietary change, where we puree from liquid, we go from solid to puree to liquid. We monitor their sugars because we don't want any contribution of the delay in gastric emptying being from postprandial hyperglycemia. And then I put in an early nasojejunal tube, which is against what most people do. They wait till they've lost enough weight that they get their BMI down to 17 and then feed them. But the more weight these girls lose, the sicker they get, the more their POTS and their MCAS flare, which is what's driving the underlying vascular compression and makes it more severe, and then they end up with that downward spiral. So I put it in to stabilize their weight and restore their nutrition, stabilize their glycemic control, while I then try and fix their underlying condition. And so I've got about 5 or 6 now that Trifecta patients that I've managed to get, it's just early days, but I've managed to get onto Xolair for their MCAS. And I'm hoping that with aggressive treatment of their POTS and their MCAS and fluid loading, and with Xolair on board, I may be able to improve their POTS and MCAS and thus improve their connective tissue enough to the point that I can avoid surgery. And we want early surgery before the symptoms become chronic, because otherwise, if you have a delayed presentation, you can restore the food passage going through, but it's not great if your outcome is, yes, I can eat, but I'm in severe chronic pain all the time. And this is, lastly, this is just one example of, this is my girl with gastroptosis. She had had a year of nasojejunal feeding, and I could not get her to gain any weight. She was stable at 50 kilos. She had one injection of Xolair, and 4 weeks later had gained 6% of her body weight. And so you can see that after a month of Xolair, this is her, you can't see her sacrum, but this is the bottom, there's the tube. This is the bottom of her stomach here, and it's moved back up. Sorry, that's not supposed to say supine. That's supposed to say erect. It's moved up. And so this was my first one that got Xolair. She was actually getting it for, she was having allergic reactions with throat swelling to most foods. And so I got a Xolair for that. We got a Xolair for that in her urticaria. But it was amazing that she managed to gain that much weight. So I'm hoping that Xolair and aggressive treatment will enable, early treatment will enable my girls to avoid surgery. But let's wait and see. And that's the end.
Well, thank you so much. This is so very informative. It's very there's a whole lot of information in there. It's yeah, so taking us a little bit to go through it all. We do have a few questions that have come through, and we might have a few more that pop up. And how long were you thinking about for questions? I know you said like another half an hour.
Questions, I'm happy to answer them.
I just know it's really late for you, so it's very early
Okay.
for me. So, oh, can you go ahead? Yeah, can you stop your screen share? Let me see if I can turn it off.
I can't do it from my end for some reason.
here.
I tried to do it before.
There we go. Okay, I got it. So, all right. So I'll bring up a couple of the questions that are here in the Q&A so far. So I'll go ahead and bring the person on and then let them answer their question. So let me get the first one. Gotta get her name on here. There we go. So Veronica, you are the first one up here. If you want to go right ahead. I don't know if you're trying to say something, you're muted. If she doesn't come up, then I'll go ahead and just ask the question, because sometimes people aren't able to speak. But so the question she has is: postprandial diarrhea can be presented as normal passing of the bowels, but not necessarily watery consistency, or does it have to be watery consistency
No,
for the postprandial diarrhea?
It's just we call it the exaggerated gastrocolic reflex. And so the normal reaction to eating is to defecate afterwards. And that's why we usually take advantage. That's why most people with a regular habit will defecate after breakfast. So it's just anyone that has an exaggerated, so people can just they eat and they just get urgency and have to rush to the toilet, and they can pass a normal motion. They can pass diarrheal, or it's just that urgency and having to rush to the toilet after a meal, which is unpleasant because you don't want to do that. And if it's early, it's usually right-sided. If it's late, and the more severe it is, the more severe the pain and the more severe the diarrhea.
Okay. And see here, our next one. Oh yeah, Veronica said sorry she can't open her mic, but I can see if I can
Not just me then.
bring her up. I'll see if I can unmute her. So I don't know. There she should be good. If you wanted to go ahead and ask anything else, Veronica, before we're you should be good now.
Hi there, can you hear me now?
Yes.
Oh, thank you very much. Yeah, no, I was just wondering because, yes, well, I'm not a doctor, I'm a scientist, but I do have a pediatric case close to us. And she's been having it's interesting because she doesn't have very set gastrointestinal symptoms, beside the fact that she's very gassy unless she takes certain types and certain combination of probiotics. So I was wondering how much, it's just this is so complicated when you think about symptoms, really, because there's so many things going on at the same time, and they are all coming from some different mechanisms. So sometimes I find it hard to know if something is really the cause or is the consequence or is both. And because they really kind of fit in each other, isn't it? So it's really...
Oh, they all impact on each other. So is it gas production as in excess flatus, or is it actually causing discomfort and bloating as well?
Well, it's not that discomforting, but it is there all the time. And I mean, it's been there for a long time, and we haven't been able to get many therapies besides.
Yeah, we do know that people with functional gut symptoms produce more flatus than normal individuals, and I'm presuming that's due to the underlying dysbiosis, and so they've got a disproportionate number of organisms that produce gas. So the fact that it gets better with probiotics suggests that that is the issue. But if probiotics are needed, it tells you that there is underlying dysbiosis. And so I would do the usual things of making sure that the patient's not fecally loaded and trying to remove that, and then looking at trying to improve the dysbiosis. When I try to improve dysbiosis, I use a combination of pre, pro, and postbiotics.
Okay.
Prebiotics, so fiber. The trouble with, and then probiotics, obviously probiotic food or probiotic tablets, and then postbiotics, I use tributyrin, which is 3 butyrate molecules joined together, which is designed to hold together until it falls apart and is released in the colon. And butyrate is the main bacterial metabolite or bacterial short-chain fatty acid that the good bacteria make. And in particular, it's good at helping restore those tight junctions, and it's also used as one of the major neurotransmitters in the brain. The trouble with prebiotics is that a lot of people, when they take fiber, don't tolerate it, and they say, I eat vegetables, I eat fiber, and I actually get worse, or they say, I get wind pain. If anyone takes a prebiotic or a probiotic and gets worse, it does suggest underlying fecal loading. If you've got hard set chunk of feces and then you put in a prebiotic or fiber and the bacteria eat it and ferment it, it'll stretch the colon. Trapped air will stretch the colon just as much as feces. The fact that it doesn't bother her is a little bit different, but I would still look at addressing the underlying dysbiosis with all of those factors. So looking at the diet, trying to remove excess fructose and other substances, looking at her mental state, because obviously excess stress will impact the dysbiosis and exercise. And if you can't find a cause for it, I will continue with the probiotics. It's not optimal to have to keep going with probiotics, but you can sometimes I get advice from naturopaths to see if I can use other supplements or diet that will help improve the microbiome naturally rather than with foodstuffs, rather than having to take probiotics.
Okay, thanks very much. Yeah, because one of my kind of worries is, as the probiotics are there, she's stable and better. But the problem is, I'm thinking if we are thinking of, if we're thinking of viral persistence as the kind of underlying cause, and we are not being able to attack that, then are we going to keep on continuing this? How can we really break that other cycle? Because unfortunately, we are not, we don't have the access to that, and mostly because she's a teenager, so there's no way I can get any antiviral for her.
No, that's the thing. I mean, I don't even have access to any test that can tell me if COVID is still replicating in the gut, and even if it was, I don't have access or approval to drugs that's going to allow me to treat it. But it's the same as if somebody's got, we know that when you look at vagal nerve stimulation in patients with refractory inflammatory bowel disease that are looking at colectomy, and they implant a vagal nerve stimulator into the abdomen, and their inflammatory bowel disease lesions will heal. And obviously it's the increased vagal tone, because we know the vagus is an anti-inflammatory nerve, but the way that it improves it is by improving the dysbiosis. And so when you increase the vagal tone improves the dysbiosis. And so I always worry that in people that have such a hyperadrenergic state, am I ever, with what I'm doing, really ever going to restore the dysbiosis if I can't control the sympathetic overactivity? And so that's why it's important to address all the issues and not just focus on one, and why these diseases are so difficult to control and get into remission, I think, because you've just got so many factors impacting and preventing you from fixing the entire patient.
Yeah, no, definitely, because and the problem is we don't have access to all of the different treatments. So you basically just work with what you have, and that gives an improvement, but of course it's not really breaking the cycle. And sorry, just the last thing, since I have the mic open, I am part of so we are trying to run a long COVID and ME kind of training for medical doctors in Mexico, because really there's a huge gap in knowledge here. And I'm also part of long COVID Latin. So I don't want to be pushy, but I would love you to be part of this training situation that we're trying to set. So we're trying to train medical doctors here with the specialist that we can find, like yourself. So we can kind of spread this, and make it better, because the patients are really, there's absolutely no attention to patients in Mexico and in Latin, and that's getting very hard for the patients.
Oh, certainly. Look, the concepts I use are all, I approach every patient in the same way, and I generally find patients present into one of two groups. They're either predominantly lower GI symptom driven, or they're upper GI symptoms driven, and the upper GI symptoms are usually the vascular compression syndromes. But I have the same process or set of steps that I go through for each patient. So once you learn the steps and you can learn this symptom is caused by this part of the quadfecta and this is how I approach it, you find that the patients that I used to find extremely difficult to treat or get improved are now easy, and it's only the ones that are severe that no one else can help me from any of the other specialties that I'm having trouble getting better. But the vast majority of mild and moderate patients, with just following those steps, get better with those. And it's quite sad, because most of it is actually getting rid of the fecal loading and improving the dysbiosis and addressing the mast cells, yet nowhere in the management of functional gut disorders. It's all based on hypnotherapy and acupuncture and antidepressants and laxatives, but very rarely is anything other than that suggested. And there are so many other things, amitriptyline. The reason amitriptyline works, which is a tricyclic, is because it's a old initial or sort of old style sedating antihistamine, and so it's the type 1 antihistamine properties that's probably doing most of it, rather than the what we say the anticholinergic, the nerve desensitizing effects. But because I can't use that anymore, because even a small dose of 10 milligrams causes severe constipation in my patients, which is, I just end up chasing my tails. But I find that these patients respond so well to H1 and H2 receptor antagonists, yet nowhere in the protocols is that even mentioned.
Yeah, sure. Okay, well, thanks very much. So
Veronica, I
Yeah.
have just sent you a DM too, for somebody in our group to contact that will also help connect you with the information you're requesting.
Okay,
About
wonderful.
so
Thank you very much.
All right, so our next question will be from Antonia. Let me just bring you up. All right, Antonios, you can go whenever you're ready.
Yep, thank you so much. It's one of the few times that I heard the concept of dysautonomic diabetes. Is there any?
It's prevalent in all my patients. I think 70% of my patients, I get them to wear a continuous glucose monitor, and they have combinations of hyper and hypoglycemia, and it's so prevalent, yet we don't even appreciate it.
I seem to be seeing it all the more often in long COVID patients, but what do we do with it? Is there any medication we can, or is it just small meals?
No. So if you have the so the treatment is a low processed carb diet. So these patients are insulin resistant. And there was a study that I did include by Cindy Shebow's group, where if you have postprandial worsening of the POTS, which means you have rapid gastric emptying, you have the postprandial insulin resistance that's equivalent to an extra 10 BMI points. So if you're a patient with a BMI of 24 and you then have postprandial worsening of your POTS, in terms of insulin resistance, you've now gone up to a BMI of 34. Yet you might be screened for diabetes with a BMI of 34, but no one's going to screen you without a family history or symptoms with a BMI of 24. And so the first step I get them to do is to go on a low processed carb diet. So I say no bread, wheat, pasta, rice, or oats, and limit your dairy because it's high in sugar. Don't use rice or oat milk because they're even higher in sugar. And that will control most of the postprandial hyperglycemia. If you find that it's not, then they need to have metformin, or if they prefer herbal equivalents, berberine added in. And then when you look at the hypoglycemia, it's depending on when it is. So if they're having a fasting hypoglycemia, don't fast, eat frequent meals, but low processed carb meals. If they're having nocturnal hypoglycemia, then have a low processed carb snack before bed. If they're not eating, then I get them to try and have a glass of protein water that's got no sugar in it by the bed. So at least when they're drinking overnight, they're getting some protein in, which is providing energy that's not related to sugar. And if they're having reactive hypos, it's the high that causes the low. But the problem is the high that precedes the low doesn't actually have to be that high. It just has to be that high for the patient. And so you can have patients that have a postprandial glucose peak of 8 millimoles. I'm sorry, I don't know how to convert that. And that will be high enough to trigger it. But normally we wouldn't be treating a postprandial sugar of 8. We'd be happy with that in a diabetic. But if that's triggering it and it's not controlled by a diet, then you add in metformin. If metformin doesn't work, you can look at extremely unpalatable corn flour. So when you have 30 grams of corn flour mixed in water, which is like drinking glue, and it reduces the absorption of glucose in the duodenum, you can use a carbose. So a carbose brake that prevents the breakdown of glucose in the proximal duodenum, so you can't absorb it. That's another diabetic tablet. And to date, that's fixed most of my patients, and I've not had problems with anything other than that. If they're tube fed, then they have to have a diabetic feed. And I also, because these patients have high risk of non-IgE based food allergies, I try to make sure that they're gluten-free and wheat-free and dairy-free as well. But at the end of the day, the nutrition is more important than the diets, but it is manageable. And what I find is that it's the activity of the disease that triggers the hypos or the dysautonomic diabetes. As you get control of the disease, then the diabetes gets under better control. So if you don't look after it, it'll self-perpetuate, but it'll start to settle down. But if you ignore it or are not aware of it, then it'll keep happening.
All right. So our next question is from somebody who has it posted as anonymous. And this one is, if stress is a major input contributing to dysfunction, how can the sympathetic nervous system be calmed? Beta blockers, other drugs, anything like that, etc.?
Depends. So like the classic hyperadrenergic or the trifecta patient I see has the stress, the psychiatric manifestations of excessive sympathetic nervous system activations. They have anxiety, they have ADHD, they have PTSD. At the end of the day, you treat them based on the symptoms. My preference for treating that type of patient is clonidine. It acts at the brainstem to reduce the sympathetic output. And so not only does it improve your POTS in terms of it reduces your sympathetic output from the source, it's also good for sedation and helping you to sleep. It's good for pain relief. It's an ADHD treatment. But the only limiting problem with clonidine is that it lowers your blood pressure, and most of my patients don't have a high enough blood pressure. So sometimes I have to then give them something like fludrocortisone in order to get their blood pressure up high enough to be able to add in the clonidine. But for that sympathetic state and that excessive stress, but there are things where a lot of times stress, what you'll find is that it's sort of a vicious cycle where patients are aware that when they get stressed, it flares their pots. And so when they go to have an argument or a situation that they know is stressed, it gets to the point where it sort of triggers the hyperadrenergic response. So even though their brain isn't stressed, their brain associates, I argue, and I usually get a hyperadrenergic response to it. And so when they have an argument, their body responds. And so that's when they usually get labeled with anxiety. And it's like, no. Anxiety starts here and ends up in the body. Or sometimes they get a POTS flare and then they become anxious. And so that's when you need to involve a psychiatrist that understands the manifestations of a hyperadrenergic state in the brain and is able to decrease the arousal. There's, the polyvagal theory of pain where you've got the layers and you have to reduce them. I don't know a lot about it, but anything that increases your vagal tone as well. You don't have to just use drugs. I recommend my patients, and it sounds wishy-washy, but we know that these things work. So anything that improves your vagal tone, so deep breathing, meditation, chanting, going outside and surrounding yourself by green nature, green trees and nature is effective. Anything gargling, anything vagal nerve stimulators. There are so many things that you can do that are free that will improve your vagal tone that no one will usually recommend to you because they just sound like they're, made up or holistic and, oh, but I've actually got physical symptoms. You do, but we know these things improve your vagal tone. So just lying on bed, if you're stressed, you go and lie on bed in a quiet room, close your eyes, and you just do your deep breathing box 4 cycles for 5 minutes, and you will activate your parasympathetic nervous system and you will calm yourself. And then there's, the EMDR, there's the tapping, there's all of these things. There is so much that is available to calm your sympathetic nervous system if you look on the internet and you Google it or you have access to them, and they're free. So there are plenty of things you can do.
All right. So thank you. Our next question is from Mike. So Mike, whenever you are ready.
I think you need to unmute him.
I hit unmute and it's still. So I don't know, maybe he needs to unmute, but I'll give him a second, and then if he doesn't respond, I'll just go ahead and ask his question. He's yeah, I've hit the unmute thing for him, so he should be good. So I'll go ahead and ask him, and then if he can come in a second, it'll do that. So Mike's question is: sometimes I feel really bad, a foul mood, feel almost like I've been poisoned. Then I have a bowel movement, and it gets noticeable, swift, and substantial relief. Is this due to the clue? Is this due to the fecal loading?
Yeah, it's amazing. It is. So when you are fecally loaded, you'll have dysbiosis. You will reduce your all of the bacterial metabolites, the short chain fatty acids that they don't float up in the blood to the brain, they go through the nerves and influence the neurotransmitters. And so your mood is directly impacted because the endochromaffin cells make 90% of the serotonin your brain uses, but the endochromaffin cells in conjunction with the bacteria, the good bacteria, make 80% of the neurotransmitters in your brain. And I see it where people come in and they're suffering from a new onset dementia that coincides with their new onset irritable bowel, which all happened to start after they got COVID. And I give them bowel prep, and they come back next time and their brain's working and they can remember things. I have people that are so anxious, it's palpable, and you can feel it, and you say to them, look, okay, let's hold off on medication, let's give you some bowel prep, and you give them 4 or 5 liters of bowel prep. They come back the next time and they're a completely different person. They haven't resorted to drugs. So yes, it's usually not that dramatic, but the more fecally loaded you are, the worse your mood will be if you're susceptible and you have genetic sort of tendencies towards depression and anxiety. And it's underappreciated. I actually think that first line treatment for anxiety and depression should be clearing the bowel out and seeing how you go. It's the same way with the keto diet. There's a whole branch of metabolic psychiatry that is treating psychiatric illnesses with a keto diet, because we know that when you go on a keto diet, you put yourself into ketosis. One of the ketones you make is butyric acid, which is a very different form of butyrate. And so you're naturally making your own short-chain fatty acids or your own postbiotics, which not only heal your leaky gut, they go to your brain and provide the neurotransmitters to improve your mental state. So that's one of the benefits of a keto diet. So yes, it is getting rid of it. So, you know, if that's what's happening and you're so sensitive, that you may be that you're a lot more fecally loaded than you appreciate.
Another question Mike had in there, so I'll go ahead and ask that since I already have him up there too. He says, I've used the continuous glucose monitor even though I'm not diabetic. During certain phases, I seem to have hypoglycemic events, especially while sleeping. Then during the other phases, I don't have them. Is this because POTS is well controlled during that time, or is there something else I was doing right during that time?
You're saying, oh, well, so the no, I'd say that it's just the activity of the POTS. The reason that you can have hypoglycemia at night is that when you go to sleep, then your vagal tone increases when you're asleep. And so if it's the sympathetic nervous system or sympathetic overactivity that's putting the sugar up and then you go to sleep, then it's going to drop. And you'll find that when your POTS settle, so when another trigger is come off, then those hypos will settle. And then when you say if your trigger is stress or your trigger is a food allergy, when your POTS flares, then the hypos can start to come back again. So it's like with anything. I mean, we need to come up with a concept of an action management plan for POTS and MCAS. So we know that if you have asthma and you have a flare, we go, okay, at the beginning signs, you start increasing your preventer puffer and you increase your reliever puffer, and you do that until you stabilize, and then you bring them back down again. And we need to realize that when you need to preempt your flares, so you need to identify your triggers. And it's hard when you can't identify your triggers, or your triggers are things that are outside your control. But if you're stable and then you lose your job or someone in your family passes away, your disease is going to get worse. And so you can wait till it gets worse, or you can go, okay, I'm stressed. I need to pay close attention to my bowels, my nutrition, my antihistamines, all of those things until that period of stress resolves. If it does, then back off rather than waiting for it. And we can't avoid stress. Some people lead incredibly stressful lives and they're susceptible to the effects of stress, but you can anticipate the effects on your body and preempt them by putting into plan a treatment plan to limit the effects on your body.
Thank you so much. Our next question is from Emmy. So let me bring you up, Emmy, and then if you're still there, you are. Let's see if this allows you to talk. So there you go.
Hello.
We hear you.
Yes. You mentioned in your presentation that you can have fecal loading without any GI symptoms. Is that right? So how do you then find out if you or your patient has?
Well, I personally think everybody is fecally loaded if they've got high POTS and unless they've got true diarrhea. The trouble is they're the hardest group to convince because they have no symptoms. It's like saying that if you've got really, really high blood pressure, you've got no symptoms, but we still need to treat it. You can get someone to feel your tummy. You can sometimes feel it. You can do a plain abdominal x-ray, or you can just take some laxatives. So, I mean, if you are fecally loaded and you start to take a gentle osmotic laxative such as Movicol every night, if you're not fecally loaded, you'll soon get diarrhea. Whereas if you're fecally loaded, you'll start taking, say, one sachet at night, and after a week, nothing's changed. You're still passing. You might be passing just a slightly bigger motion. But if you weren't fecally loaded, you'd have diarrhea by now. So then I say, okay, well, the next week, increase it to 2 sachets at night. And you do that, and again, nothing happens. You're just clearing out the backlog. And so I'd say, okay, increase it until you get to the point where your motions start to become too loose, and then go backwards to halfway between that dose. But that's the easiest way to do it. The other alternative is you can go, okay, well, I'm not that fecally loaded. I might just try and improve my microbiome. and add in a prebiotic. But if you're fecally loaded and you add in a prebiotic, such as fiber, it can actually make you worse. And so I've seen people that were going every day and I thought, oh, they're mild, I probably don't need a laxative, I can just get away with some fiber. Or I say to them, add in the fiber later, and they're mistaken and add it in at the time. And then the fiber they start taking fiber and laxatives and they end up more constipated than they were because the fiber worsens things. So I would take a trial of gentle laxatives. And everyone says, oh, I don't want to be addicted to laxatives. It can't be good to take these things. And I'm of the opinion, well, you're not addicted to laxatives. You're treating your fecal loading. You're treating your constipation, just like you're treating your high blood pressure. And when you stop treating it, you go back to your normal constipated state. So we treat you until we can find out why you're fecally loaded and correct that. And when we correct that, then we can stop the laxatives. And I actually think the consequences of fecal loading and dysbiosis are actually worse than taking a laxative long term.
Right, thank you. Yeah, my second question was about treatments, but I think you answered that already. So, yeah.
All right, and thank you. And then we've got one more question in the Q&A, but this person's had to leave. Oh, we've got two in here. So I'm going to ask, I'll go ahead and bring on the one that just popped in because the other one had to leave. So we'll bring in this. So I'll bring in Debbie. So.
Thank you. Can you hear me?
Yes, we can.
This talk is amazing. And I'm then thinking, how can we find functional GI specialists in our local areas who have the same mindset as you?
Yes, I can't find very many near me either. So unfortunately, there's very little interest in functional gut disorders. And I'm not sure if it's because it's mainly women and women complaining of weird symptoms that no one knows how to manage, or because it's thought it's not important, it doesn't kill you. I'm going to focus on the diseases that are important, like bowel cancer and inflammatory bowel disease, because they kill you. There's just a distinct lack of interest, and particularly in private. Whereas in public, they don't have the fund, or in Australia, they don't have the funding and the setup to manage functional gut disorders because they're not life-threatening. So they need to focus their limited resources on things that are going to impact. But these are horrible chronic conditions that can lead to people not being able to work, not being able to go out, not being able to eat and enjoy their life. So the answer is I don't know. I'm trying to turn that protocol into like an AI patient app where you put your symptoms in and any investigations, and it takes you through a step because you put your symptoms in, and if you describe your symptoms well enough, then the answer's the same. I mean, the number of people that come to see me that have had diarrhea for 20 years, and I give them bowel prep, and they just ask that, and I explain the reason, and they walk out, and you can see, this woman's a bit crazy and had diarrhea for 20 years, and she gave me bowel prep. And then they come back and they go, oh my gosh, I can't believe that I haven't seen you before because it got rid of my diarrhea. But we're not taught about functional gut disorders. We're taught about the things that are, we're not taught about hemorrhoids or fissures either as gastroenterologists. Yet what do you see in private practice? You see functional gut disorders and you see hemorrhoids and fissures. And we're just not taught about it, and no one seems to be interested. So unfortunately, I don't know how to answer that question. But I mean, hopefully with what's put in there, then, you can look at those symptoms and the symptom generation and follow flow charts and things and work your way through your symptoms, and then find there are a lot of good naturopaths and dietitians out there as well.
Well, thank you. It is, yeah, that's always kind of a question too. It's like whenever we have our speakers on here and everybody wants to know, like, how do we find someone like you? And so hopefully that's part of the idea of our series is to kind of like, help connect other clinicians so that way we can have them share information and actually help to look into these things. We do have one more question in the Q&A, and then I'll turn it over to any of the panelists that would like a question. This one, the person said they had to leave, so I'll just go ahead and ask the question. Is there any particular specific strains of probiotics regarding the fecal loading that you would recommend?
No, the trouble I find is that, do we even know what the ideal microbiome is? I mean, we sample the feces that comes out from the rectum, but is that even representative of the entire colon? I think there are multiple ideal microbiomes. So no, I mean, there's so much research out there. I try to get a good strain that has good cover for all of the good bacteria, but again, it's trial and error, and I don't overly focus. But probiotics can be very expensive. I try and, if you can, eat probiotic foods. The only problem with probiotic foods are most fermented foods, so yogurt, kimchi, sauerkraut, kombucha, things like that. The problem with probiotic foods, though, is that they're high in histamine, and so those that have a histamine intolerance are not able to, and so then you can get probiotics that are low histamine straining. But it's trial and error, and people say, oh, I'll do a microbiome analysis. The problem I have with microbiome analysis is you can change your diet, and within 4 days you'll change your microbiome if you eat healthily enough. And so if I'm going to do a microbiome analysis, because they're expensive, I recommend that, one, I only do them in sort of motivated patients, and I make sure that I've completely cleared out their fecal loading. I've adjusted their diet. I've got all the pre and the pro and everything on, and I've maximized everything. And if they still have symptoms, or if they still want to do it, then I do the microbiome and then supplement what they're deficient in. Because if you're fecally loaded and you do your microbiome, you're going to get one answer, but then if you clean the feces out and do it again, you'll get a completely different answer. So you've got to optimize everything. But I would just start with a general probiotic that's good for gut health. It's based on cost, but otherwise probiotic foods.
Okay, well, thank you. So any of the panelists, do you have any questions? Go ahead, Ellie.
Yes, do you recommend that we each get continuous glucose monitors?
I think if you've got those symptoms, so if you've got any traditional risk factors for diabetes or family history, or if you have peak polycystic ovaries or any other diseases, gestational diabetes that are, or if you've got an elevated BMI, particularly with central adiposity, then if you've got those and POTS, then yes, definitely. But otherwise, the screening of asking, do you get hangry, you know, asking those hypo questions, and then postprandial hypoglycemia is quite sensitive to the postprandial worsening of POTS symptoms. So if you've got those, you can get a trial in Australia for sort of $15, but otherwise they're quite expensive. So if you can get a trial and do it, and then, you know, they last for 10 days, and so I say do it, and if you see, then or they last 2 weeks, for the first week you do it, see what the pattern is, and then implement the diet change and see if it stabilizes on them. And then it's affordable. But for my patients that are really sick and my patients that are on nasojejunal tube feeding, I do write a letter to allow them to be able to access continuous glucose monitors that are subsidized at the type 1 diabetic rate.
Thank you.
In a similar vein, is there an imaging basis to evaluate the fecal loading and some of the other aspects?
Yeah, definitely. So most people have already had imaging when they come to see me. So I'll ask them, have they had imaging? And I'll go back and I'll have a look at that. And there is the characteristic, you have to look at the films yourself. And I've been surprised that fecal loading is very rarely mentioned, even when it's there. And a lot of times I do x-rays to say, please tell me the degree of fecal loading. I've just cleaned them out. And they say none. And then I look at the films, it's like, okay, well, they're chock full of feces. So it has characteristic patterns on CT and abdo x-ray, but you have to look at the films yourself. And the reason for that is I think that most radiologists learn radiology in a tertiary hospital that is full of extremely sick people. What do extremely sick people have? Dysfunction of the gut-brain axis and fecal loading. So they learn that a normal x-ray is actually a fecal loaded x-ray. So yeah, so you have to look at it, but no, and a plain abdominal x-ray, but looking at your old films, I mean, if you've been fecally loaded in the past and were or were not aware of it. But, people that have had diarrhea for 20 years, and I look back through their imaging and they've been fecally loaded. The other thing I ask is their response to colonoscopy. So if you say to a patient, I ask two things. I say, when my patients have a colonoscopy, I say, I want you to tell me how you feel the next day, because all I've done is clean your feces out. So if you're one of these people that go, oh, I woke up from the colonoscopy and I felt amazing, and then a week later I felt exactly the same, well, your colon was empty and then it filled up again. And the other question I ask them is, how long does it take you to do your first bowel motion after the colonoscopy? Because by the time you start eating and drinking, normally after the colonoscopy, you should have your first formed bowel motion that night, if it's a morning procedure, or the next day. So if you take a week to do your first bowel motion, then we've got some serious problems. And I see people that 2 weeks after a colonoscopy, and I've had them go straight back on their laxatives, and I feel their abdomen and it's just full again. And it's just really disappointing, because sometimes it takes so much effort to clear you out. You want to make sure that when you're cleared out, you do not let it rebuild again. But yeah, so there's some of the ways to gauge.
So for people who have the symptoms of fecal loading frequently, would you recommend first doing something like a colonoscopy prep and then doing the laxative periodically?
It really depends how bad it is. So if I find that, you start off with just constipation, and then as it gets worse, you get the alternating diarrhea and constipation. And then it gets more severe where it's the abdominal pain and the diarrhea, and then if it's so severe that people are passing out and becoming pre-syncopal from the pain, then they're really, really loaded. It really depends on the person, how much time they've got, and whether they're really what I call marcelli, because some patients react really poorly to the ingredients in the bowel prep. In Australia, it's not easy to get a bowel prep that's sulfite-free, but if you can, I think there are some available in America, because I have patients that I give bowel prep to and I make them worse, even though they're fecally loaded. And there's that very small subset of patients that wake up from a colonoscopy and I'm expecting them to tell me how amazing they feel, and they go, oh God, I feel worse. I'm so bloated. I feel so full, but you're empty. And so I think that their mast cells in their bowel are reacting to an ingredient in the bowel prep and triggering them. So even though they wake up and they're empty, their mast cells are degranulating in their gut and causing worsening symptoms. So I usually just, if it's constipation or alternating constipation, diarrhea, I usually start just with the laxatives, like on my website with the sheet, and just start and just increase. If they're intolerant to osmotic laxatives, there's two reasons for that. They either have severe rectal hypersensitivity, which you sometimes can't pick unless you've done the anal manometry, which is where as soon as a small amount of feces drops into the rectum, they get the urge and they've got to go, in which case they're better off with the stimulant laxatives. Or people that are so fecally loaded that when they take the laxatives and just that extra little bit of fluid that sits in their colon and expands their colon causes excruciating pain. Because laxatives shouldn't cause, like the osmotic laxatives shouldn't cause pain. So if a laxative is causing pain, either it's osmotic or even one of the stimulant ones, it's because as the bowel's contracting, it's contracting on hard feces and it's pushing on it. So if you're getting severe pain from laxatives, it means you're really chock full. And so, yes, you can go for laxatives, but I have people that I give bowel prep to, and if I think someone's really fecally loaded, I'll start with gentle laxatives and I'll postpone their colonoscopy for say 4 to 6 weeks, so that I have getting them in, easing them into it, so that when they hit them with the bowel prep, then they're going to tolerate it better. But I have with people that have their bowel prep and they pass out and have to go to the emergency department because they're so much pain from the bowel prep. And if that's the case, then that's when I resort to colonic irrigation. But even that can be painful because of the distension. So it's just getting a feel for it and trying to put all those factors in. The trouble is when you also give bowel prep, and the way I do bowel prep is I say, depends how much time they've got and their nutrition. I say make up 1 to 2 liters of bowel prep, and I said, and I do the large volume ones because they're generally gentler on the bowel than than the Clenbuterol or one of those, which is quite vicious. But I say drink 1 to 2 litres of bowel prep a day whilst you're still eating and drinking. We're not doing a colonoscopy until the bowel return looks like urine. So it's yellow and clear and see-through. And then we know that we've dissolved all the feces, then start the laxatives. But sometimes if the bowel's slow, they start the laxatives and then a week later they've still got diarrhea, and then they stop the laxatives, but it's still the bowel prep coming through, and then it can be difficult and you end up all over the place, and it can take a while to reset. So it really just depends on the patient.
Anybody else have any other questions? I'm surprised you don't have a whole bunch, Sam. You always have a bunch. I think we're kind of all processing everything that you're saying, and we're coming up with our, like, okay, I wonder if this causes, thinking about various parts of it. So it's just, yeah.
Veronica just asked if there are any specific laxatives that you suggest.
So for the osmotic laxatives, whatever you've got in your country, I use we have Movicol or Osmolax. They're macrogol-based ones. And then if they're not working or you need extra, then any of the stimulant laxatives, I use Bisacodal or Caloxyl and Senna. The herbal Senna laxatives tend to cause more of the melanosis coli, which is not a problem, but stains the lining of the bowel black. There's a lot of herbal laxatives. So people will say, oh, I'm not on a laxative, and I'm on this herbal mix, a slippery elm, and a lot of the herbal ones people will tolerate better. At the end of the day, I don't really care what you take. I find a lot of the herbal ones can be very pricey. You end up getting this $100 fiber laxative supplement that lasts you 2 weeks when, some good old $5 Caloxyl Senna from the chemist will do the same job. So if something works for a patient, I'm not going to change it. And the other thing is magnesium oxide or Oxymag. So it's MgO7. I use that for my people that are quite sensitive, because some people react to the ingredients in just the simple osmotic laxatives and they can't tolerate it. And some people's mast cells are so sensitive, they just react to anything they put in their mouth. And so in those patients, I do recommend the magnesium oxide, but it's just a matter of finding the right dose. You do have to drink it with water. It's very important when you take magnesium. There's so many different forms of magnesium. So you have to say, what are you taking it for? Some work for your bowel, some work for cramps, some work for sleep. So just got to decide what you're taking it for.
And Mike has another question, and I'll see if I can get him to see if the thing will actually work this time for him. It's like not wanting to let it go. I mean, the little thing's not like doing, no, it's something to it. So I don't know if you're there, Mike, or not, but I'll go ahead and ask your question if you don't pop in, because I have it on there and it's just not letting, I'm not bringing him up. So I don't know. It's only Mike it seems to be happening to. I'm sorry, Mike. But all right, so his question is, do you have an opinion on integrity? So it looks like prucalopride, or does that not fix the root cause of fecal loading?
Prucalopride's good. I don't know what it's like in other countries. In Australia, it's $70 a month, and that's a lot of money. And so I've never used it purely because of the cost price. If this is something that you need to be on long term, that's very expensive. I've started to look at it more because of its effect on gastric emptying. So if I have patients that are constipated and have symptoms of slow gastric emptying, prucalopride, the 5-HT4 agonist, it will cause stimulation of colonic contractions, and it will also facilitate gastric emptying. If you've got money, it's good, and it reduces the amount of other laxatives that you need to take. It's just, I usually just find the patients can't justify the cost. And we don't have the other agents available in Australia that you guys have as well. So I don't use those either.
Oh,
Ellie?
go ahead, Ellie. You're muted.
Sorry. Can you go over again a little bit about the connection between severity, the mild, moderate, the severe? Is this all coming from the fecal loading?
Sorry, what was that? What symptoms?
The level, the degree of symptoms, the very severe bedbound versus the people who are miserable but upright and walking around.
It really depends on, it's like with any symptom, I look at it and I go, what's stopping you from being upright? Is it your fatigue? Is it your PEM? Is it your postural tachycardia? Is it your pre-syncope? I find that by the time people get their POTS to the point that they can't stand upright without passing out or becoming pre-syncope, they're not getting better without fluids. And particularly if they're grossly fecally loaded, I can't win. If you're so hypovolemic that you're needing fluids to stay upright, then you're just constantly taking any excess fluid from your colon. I mean, I've just recently had a woman that's, she's actually a doctor, and she's been extremely unwell, and she's been having sort of intravenous fluids, 2 litres 2 or 3 times a week, just so that she can work a few days. And we aggressively attacked her neck because she had, you know, upper cervical spine dysfunction, which was contributing. By the time I next saw her, she had a port. We're giving her 2 litres a day, and she had 12 colonic irrigations. And then we played around with her meds. And for the first time in 2 years, we're finally fine-tuning it. But I can't fix it in isolation, and I have a lot of trouble fixing the bowel in people that are that sick without access to IV fluids, and that's the problem. I do have emergency departments and a few GPs that will agree to do sort of a couple of litres of fluid a week for a patient, but some of these patients need 2 litres of fluid a week, and if you can't, like, you've got to stabilise the disease then to get it better. And if I can't even stabilise you, how do I get you better? But we're just, our medical system is, and I'm assuming everyone around the world is the same, no one understands these diseases, and no one's going to admit you for fluids because, well, how do fluids fix someone? You know, they just don't, and we just don't have the resources to bring people in for fluids.
I did IV a liter or 2 at home once a week for 6 years. I had a family member learn how to put in the line, so I could save money by just ordering the supply. Because when I would go to the doctor's office, would do it, but the nurses would get so angry at having to do it for me that the stress of interacting with them
Exactly. What if
made
everybody
me
else wants?
Yeah. So the stress causes you to run and dump the fluid out urine.
No, fluids is such a simple intervention, and it just makes all the difference. I mean, when people talk, I mean, when my patients come into hospital, I used to just give them 2 to 3 litres of normal saline a day. And after about a week, they'd say, is this what it feels like to be human? My brain works and I don't feel like I'm half dead. And I'm like, yeah, that's what it feels like. I thought, this is my gift to you. And if people come in for colonoscopies, I give them as much fluid as I can in the time that they're there. And I mean, it's a form of preload failure. Everyone goes, oh, you can't give a litre of saline over an hour, they might overload. It's like, this is a 20-year-old girl with a structurally normal heart. She just needs some fluid to get into her heart. And so I give them a litre of saline over an hour. I've got another general physician I work with, and when patients come into hospital, he gives them a litre every 2 hours until they beg him to stop because they're sick of going to the toilet. And he says, and then they go, enough, and then he just drops them back to the maintenance rate. And these girls, their brains turn on for the first time, and they feel good, and then they drop back and they go, oh, now I feel terrible, my brain doesn't work. So
That's wonderful. I had a doctor actually write me a letter to carry in my
yeah, no,
in my wallet, so I could walk into an ER and say, this is what my doctor recommends.
Some people follow it and some people don't. So
Right.
Yeah.
It's better than just asking on your own, though.
yeah, no, definitely.
Yeah. All right. It looks like we are out of questions. Thank you so much, Dr. Ryan, for being here today. Thank you for your expertise, and thank you for not shying away from the complexity that we represent, and for being willing to share your expertise with other clinicians and patients with information that they can bring to their clinicians, and hopefully
thank you
we
for
start to
your
make an
endeavour.
impact.
No, it's a fantastic organisation, and I was copying your nicotine test information today to give out to my patients. So there's lots of resources, and it's sorely needed, and it's only going to get worse, isn't it? So
Amazing. The more information we all share, the better we are.
definitely. Well, thank you very
Yeah.
much.
All right. Thank you so much. Have a great day.
Okay, see you later.
Yep. Bye-bye.